Trigger warning. This content includes sensitive material related to suicide, trauma, and/or severe mental health concerns.
It is my pleasure to introduce our speaker panel for the afternoon. That includes Dr. Margaret Rutherford. She is a clinical psychologist who has practiced for over 25 years in Fayetteville, Arkansas. Her passion within the last decade has been to bring compassion and common sense advice to her audiences through her own website, as well as being featured in Psychology Today, Psych Central, Himalaya, the Gottman blog, and others. She hosts a highly popular podcast, the Self-Work Podcast, which is consistently ranked in the top 50 of U.S. mental health podcasts and has been chosen by several mental health websites as among the best mental health podcasts of 2021. Her book, Perfectly Hidden Depression, also focuses on much-needed light for dangerous link between destructive perfectionism, depression, and suicidal thought, and earned a spot in Parade Magazine's top 10 books on depression for 2021. More recently, her instructive and fast-paced seminars on PHD, Perfectly Hidden Depression, have been acclaimed by participants as one of the best ever, as she offers a challenge to the mental health profession's over-reliance on its classic symptom checklists during assessment and evaluation of depression. Dr. Leigh Anne Bennett received her medical degree from the University of Arkansas for Medical Sciences in 2000 and completed her psychiatry residency during 2004. Following residency, she began practicing at the Arkansas Psychiatric Clinic, which has remained her home base of practice since. She has also worked in community mental health with Health Resources of Arkansas, practiced inpatient psychiatry at the Bridgeway and Baptist Health, participated in clinical trials through APC Research, and was the medical director for Bradford Health Services of Little Rock until 2020. She continues in partnership with Senior Works, which provides psychiatric services to residents of nursing homes. She is a She is a board certified in general adult psychiatry and is also a member of the American Psychiatric Association, Arkansas Psychiatric Society, American Medical Association, and the Arkansas Medical Society. Her realm of practice includes outpatient medication management for adults with emphasis on treatment of mood and anxiety disorders, PTSD, ADHD, and substance abuse disorders. Her main area of interest is in women's mental health, with a primary focus on treating perinatal psychiatric disorders. Chris Thomas is co-founder of the Defensive Line and serves as Chief Executive Officer. Chris has yet to meet a stranger. During his 30-plus years in corporate management of consumer goods and products, both domestically and internationally, Chris has literally made thousands of friends through his innate ability to connect with and care for others. People are put at ease by his big laugh and zest for life and his ability to communicate a message of positivity and hope. A gifted college athlete, Chris played an integral role in coaching and developing the athletic achievements of his children, Ella and Solomon. Chris also jokes that, as Solomon's dad, he had the rare privilege of raising his own favorite NFL player, and no player has a more enthusiastic father in the stands. Chris's passion for suicide prevention programming developed by the Defensive Line is only surpassed by his insistence that people of color are provided mental health care on an equitable basis. His lived experience helps train others on recognizing and reacting appropriately to microaggressions when they occur. This level of nuanced discussion makes for a deep and meaningful, purposeful presentation. Martha Thomas is co-founder of the Defensive Line and the Chief Education Officer. Martha exudes warmth and welcome to everyone she meets. Her 30-plus years as an educator have proven invaluable to the Defensive Line, where she serves as Chief Education Officer, the other CEO. Her insight of the realities of classroom provides an understanding of what teachers are faced with every day. She left teaching in 2022 to work full-time with the Defensive Line, where she continues to educate through suicide prevention workshops and D-Lines training. Martha co-founded the Defensive Line to honor her daughter, Ella, and to bring a message of hope and help to other at-risk young people. She's a respected voice in the field of mental health, a popular podcast guest, and an inspiring keynote speaker. Thank you all for joining us today.
Hold your applause. You just heard the credentials of these three people, and they're very powerful credentials. But the reason they are here today and what we're going to do is to talk about their loved ones who died by suicide. Leigh Anne's father was a physician, highly, highly regarded in southern Arkansas, Searcy, and died by suicide when she was in medical school. So she has started the Elliot Foundation that has been going quite a long way, or many years in Searcy. And let me see if I can, their mission statement is to build bridges of understanding about the disease of depression, save lives, and restore hope. Chris and Martha, who I actually met through my cousin in Dallas, she said, I think you ought to get to know these people. And their daughter Ella died by suicide when she was 24. All three of them are going to speak about their lived experience, and like Dr. Harvin said, Chris and Martha have started the defensive line with their son Solomon, who is an NFL linebacker with, right now, the Dallas Cowboys. So I am very honored that they have chosen we're not here to talk about statistics, we're not here to talk about anything other than their personal experience, their personal tragedy, what they have found out since then. We had a wonderful conversation about a week ago, and Martha just said to me, let's just have the same conversation over again. So this is different from, we had some wonderful presentations this morning, and of course we got John Summers Flanagan tomorrow, and I am very, very pleased to have you all. So, begin with letting us get to know your dad, Robert, and your daughter, Ella. And those microphones are for you. Leigh Anne, why don't you start?
Can y'all hear me? Okay.
You have to kind of eat it a little bit.
Let me not do that. Now, I'm very soft-spoken, so hopefully this will help. I am curious, I guess, a question. How many of you in this room have been touched by suicide, if you're comfortable with sharing that? Okay. I admit I thought more than that, but that's all one too many. So for me and my family and our community, our life was forever changed back January 13th, 2001. That was the day that my father ended his life. He was born and raised in Searcy, Arkansas. He was a radiologist. He'd been there practicing for 30 plus years. I feel this way in the community as well. He was a gifted physician. The work he devoted his life to was saving lives. That was his mission in life, enhancing the welfare of others. But in addition to that, he was a pillar of his community, wonderful father, grandfather, brother, uncle, friend, confidant to so many. So the day of his passing, you can imagine that community. They were devastated. They were without answers, tons of questions. And again, how could this man who devoted his life to helping others and felt that life was worth living could end his life? So we pretty much recognized that at that point in time, like it had to be just too difficult to keep living. At that time, he had been dealing with a very severe case of depression. It actually had only began about a year and a half prior to that. And when I say began, there's a good likelihood he'd had depression other times in his life. We just didn't understand, or we didn't know, we didn't recognize it. It wasn't something that... Oh, I'm sorry. Okay, is this better? Ah, okay, I didn't want it to make that sound. So about at that time, I was a third-year medical student. I was trying to decide on what was my path forward. What was my specialty going to be? And I had finally done my rotation in psychiatry, and I knew that was it. And I just felt like there were so many unheard voices, people who needed someone to speak on their behalf. So you're talking in the late 90s. This was 98, 99. But I knew it was going to be very difficult to go to my dad, the radiologist, very scientifically oriented in his way of thinking, and say, this is what I want to do. So I finally got the courage up, talked to him, and he just looked at me at first and he goes, He goes, I just don't. He said, why did you go to medical school if that's what you were going to do? Why did you go that path and endure all of that? So we talked a little. We both kind of ended, I'm frustrated, he's confused. So I went on my journey, and this was a man that I highly respected his opinion. And what I did not know was during the 3 months of that summer, he sought out prior medical students that he knew that went into psychiatry, talked to them. He even had a good friend that had gone into it, talked to them to find out why. What is it about it? August of '99, he then came to me. I was in my 4th year of medical school, starting on rotations for psychiatry, and he said, I get it. He said, I think I finally understand why you're called to that. He said, but aren't you afraid it's going to be too hard? So in that brief time, he had a sense of what that could be like, helping people that went through those struggles. Oh, sorry. It was not until, it was just 1 month after that, that he developed the first signs of depression that we were aware of. And it was unbelievable. I mean, not sleeping, despair, all the severe symptoms of depression. And it went on for a while. He went to treatment, but you didn't go to treatment back then. He was a physician. He was well known. It's just not what you did. So even the psychiatrist that treated him, he would not allow him to write anything down. He wanted no record of what happened. And so as all good physicians do, they like to treat themselves. So they would do a lot of medications, and he would adjust them. And at one point, there was a turning point, or so we thought. What we didn't know at the time is that he became manic. So, but we just saw he was friendly, he was laughing, he wasn't in despair. And here I am at this point in my 4th year of medical school. I didn't have a clue about psychiatry, and this is what I was picking for my major, for my specialty. So we were so happy, like I said, we didn't think much about it. We thought, okay, maybe it's over and done with. And I remember him telling me during that state, he said that he could never go back down that dark, deep hole ever again. It was within a few months, I was in residency, and he, again, suffered a very severe depression that he never recovered from. And he was seeking out help. We finally had gotten him to agree to go to a therapist. We couldn't do it at this point. We were looking at ECT treatments. We were looking at all sorts of things. And he said, why do y'all want to end my life? He couldn't understand what we were trying to do. So he agreed to go to this therapist. But on the morning of his death, he ended up saying, I do not think I can bare my soul to someone. He just wasn't raised in an environment where you talked about what happened, how you were feeling. He was the rock that others turned to, not the one that was to need help. So when his death came, the community, everyone just fell apart. Because if it could happen to him, it could happen to anyone. And I think that was the thing I learned back at that point in time, is that no one's immune to it. There's no boundaries to it. It does not discriminate. So all of these community people from Searcy, a lot were born and raised there. Most of them had known my dad through the work. One of the things I did mention was that he, being a radiologist, his main specialty was breast cancer diagnosis. He spent lots of time and effort towards the diagnosis, working with UAMS to figure out the program where you can go from diagnosis to reconstructive surgery, so the woman wouldn't have to go through all these different providers. He was instrumental in breast care legislation being passed. So again, a man that life was valuable to him. So our first meeting of just a group of friends, not knowing that we were going to develop or start anything, we all just sat around, tearful, talked about stories about him. We were like, what can we do? And that was when we decided that people needed to understand that there are people suffering that feel ashamed and that they need to be able to speak out. And we needed to help be a voice by them by breaking the silence. And so it was at that point, it was March of 2001. He had passed on January 13th of 2001, that we started the Dr. Robert E. Elliot Foundation, and it has been in existence ever since that date. One of the things that my mother, and I don't know if the people from the American Foundation for Suicide Prevention are still here, but in 2002, my mother and I participated in the first overnight walk in Washington, D.C. We did 26 miles. My mother did 16. She was 62 at the time. Well, actually, there was a group of us with the president of AFSP at the time that we got lost. Somehow one of the little markers got turned and we walked 2 extra miles. They had to hold up the entire ceremony. And here's 800 of us out of 2,300 that signed up for that. And so anyway, so that was really cool because that was the first walk that our foundation did in Searcy, Arkansas. And so the one for AFSP was out of the darkness. Ours was into the light. And it coincided with us walking into them starting theirs that next day. So there's just been so much good that we've tried to turn my dad's tragic death into. And I felt like it was my way to continue his mission in life, which was to improve and enhance the welfare and life of others. He just did not know that the focus would be on helping save people's lives. So, but thank you all for allowing us to be here today to share these stories.
Sure, yeah, exactly. Martha and Chris, tell us about Ella.
Well, our daughter Ella died by suicide on January 23rd of 2018. That's how she died, but it's not how she lived. So I'll tell you a little bit about how she lived, because she was feisty and a fighter. She was born on April 19th in 1993, 9 weeks premature, and came out fighting. They said she'd be in the hospital for 3 to 4 months, and she would be a very, very sick person. She wasn't sick. She was a fighter, and she was in the hospital 3 weeks and came home before she turned 5 pounds, because I learned how to be a mama bear almost immediately. And I sat and argued with the doctors, and I said, you are not doing anything for her here that I can't do better at home. And he looked at me and he said, okay, fine. You can take her home, because they had a rule then, 5 pounds. They had to be 5 pounds before they could go home. But she had her feeding tubes out, and so we got to take her home. She lived life with so much love and so much light. She, however, was not perfect. And as a young woman, never met a party she didn't like, never met a person, good or bad, that she didn't want to spend time with. So she was a lot. We lived in Australia for 5 years as a child, and both of our kids, Ella and Solomon, developed Australian accents that were so thick that when we moved back to the U.S., they put them in speech therapy because they said they couldn't understand them in school. And they didn't know. They had learned, the metric system. They had learned all this other language, and they were both a hot mess. My kids were each other's best friends. Our kids, sorry, Chris, were each other's best friends. It was almost as if they had their own language. They say twins have their own language. It felt sometimes like Chris and I were just bystanders in their world. Maybe that's what parents are. I don't know, just bystanders in their kids' world. But Ella loved to serve. When she was in younger years of high school, we used to go serve at a homeless shelter. And on Christmas Eve, we were there, and we went on a regular basis. So it wasn't just the Christmas Eve service that we were there for, but she had no problem. The rest of us were standing around the edges, and Ella decided, these people were getting bags of things and gifts, and Ella decided she would help them carry their food back to their cots. And so she was walking through all the cots, and one man stopped her and he said, "I want to give you something." And he gave her a bottle of shampoo. And she came back, and Chris and I were mortified. She was taking something from a homeless man. You know, he needed his shampoo, and we both said to her, "You got to give it back. You got to go give that back." And she said, "No, he needed to give." And that bottle of shampoo is still in her room. But we had, we like to talk about our family because we're a nice family. We didn't have all sorts of crazy problems. I mean, we had problems. We're a family, and aside from our obvious differences, we're a pretty normal family. We sat and we ate together. We prayed together. We went to church together. We supported our kids in their sporting events, any activities. Ella played the trombone in band. Solomon was in drama. We did all those things together as a family, took wonderful vacations around the world together. Our kids were the best world travelers. And, you know, they opened up so much of the world to us because especially Ella was fearless. Ella was also off the charts ADHD. And part of that, I think, her being so early, prematurely aggravated, whatever. She would have been ADHD anyways. But she was really well behaved in school and did okay. So we couldn't get services for her in Texas. But school got a lot harder for her as she got older. And she came, we live outside of Dallas, and she came to the University of Arkansas. And we thought that that would be a wonderful place for her. They had, you all have more support in Arkansas for people with ADHD. And she could get services, but she was mortified that she would need extra time or extra help because she had been never allowed those things. And her freshman year was a big struggle. She was doing much better her sophomore year, and then things fell off the rails. And we didn't know for a long time what had happened to her. She was gang raped at a frat party and was so terrified to tell anyone, except a few friends, who said that everything changed for Ella after that. But one of the things that we've learned along the way is that sharing information about each other isn't gossip. It's life-saving information. If we had known some of the things that had happened earlier, perhaps we could have gotten her help. We will always live somewhat in the could-have, would-have, should-haves. Ella was getting therapy when she died, but those demons just that had invaded her and that rape never really left her. She stayed in Fayetteville afterwards. She was supporting herself. She was an incredible bartender, which apparently people with ADHD are really good servers and bartenders. I used to love to sit in her bar and watch her. Like, how can you remember what that guy ordered and keep his tab going, but you can't remember your math facts? And she could do the bar math in her head, but could never remember her math facts. Trying to learn Spanish was terrible. Anything she had to remember, unless it was lyrics of a song, she couldn't. So there were challenges along the way that we certainly know now that combined could be more of a problem than we thought then. So
the only thing I'll add is one of the things that after Ella died by suicide, you know, aside from just the gut loss of losing your child and the pain, there was this bewilderment for myself because I didn't think black people died by suicide. And when we raised Ellen Solomon, one of the things I wanted to make sure is that they were raised with lots of love. You know, there was a presentation earlier that talked about adverse childhood experiences. You know, I had 6 or 7. You know, my father beat me with everything that you can think of, whether it's a utility belt, whether it's, you know, extension cord, a stick, whatever. I mean, so I know what it's like to not be loved or to be abused physically, racially, sexually. So we knew that when we raised Ellen Solomon, they were going to be raised with absolute love, and they were. But sometimes love is not enough. And as Martha said, you know, we vacationed together, we prayed together, you know, we did all these things together. This is a picture of our, didn't know at the time, but was our last vacation we had with Ella. Was about a week or so after Solomon was drafted. He was the 3rd pick in the 1st round in 2017. And, you know, so it's, I mean, one of the things I always think about is just the juxtaposition. You know, Solomon, sky high, you know, the top of his game, and then at the same time Ella was going down, and it's just in the same period. And none of us, Martha said, you know, she was getting all the help she needed, she was on the right medication, but none of us recognized that the pain she was going in. And I really do think it was just, she was in so much pain. You know, aside from the rape, she was also in an abusive relationship. So I think all of those things, you know, led to her taking her life on January 23rd of 2018.
So now, what do you now believe, or what have you discovered that you didn't know at that time when your loved one died?
Everything. First of all, I feel like I'm a different person. My core is still the same, I guess, but you know, we both have this hunger for knowledge, and sometimes I forget. I have to remind myself what I didn't know 8 years ago, and make sure that our mission is to teach people to know what we know. We're not clinicians, we're not licensed therapists, we are just normal people trying to share information, trying to share ways that people can fine-tune their hearing to know the things that we didn't know, and to know the things that we've learned along the way. So I really didn't think that we knew our daughter was struggling. I didn't think suicide was in her, you know, somewhere where she would be.
Didn't know suicide was even an option for her in her mind. Yeah.
Right. Yeah, like we loved her. She knew she was loved.
Yeah, yeah.
We had a nice home. We're good people in general.
But the Leigh Anne's point earlier, it's this, the whole piece on suicide is you could be in the clubhouse or you could be in the curb on the street. It is
Great
leveler. It's
leveler.
indiscriminate. It is a great leveler. It really is. And then we talk about, you know, it doesn't matter whether you're a Christian or a Hindu or atheist or rich or poor or black or white. I mean, it is a great leveler. And she asked earlier, you know, how many of you have been touched by suicide? And typically, you know, it's at least half the room that typically gets up. It's just, but I didn't know anything about it at all until Ella. But then we started learning more about it because we want nobody else to go through the pain that we've gone through. We always said we wouldn't wish it on our worst enemy. And whatever we can do to help others, in particular those who don't typically get the attention, the underserved, whether it's Latino, Native American, African American, the rural community. I mean, just the number of mental health deserts that exist across our country, we need to give them the information to help them understand that this is an issue that needs to be addressed. So, but part of it is having these discussions to normalize the conversation, but then also to help people know that this is something you should be looking out for. And it's
scary, isn't it?
It's scary, yes, absolutely.
mean, just to add to what they said as well, I mean, here I was, a resident of psychiatry, and all the training and learning that I got about how to talk to someone that might have suicidal thoughts did not come from my training. It came from my unfortunate lived experience and delving into it and asking to do the lectures on it, to talk with people about it. And it was, as a clinician, you're talked about not talking about yourself when you're with patients. But the one thing I've learned over these years, the more times I share my story, even with a patient, it makes a difference. And I had one particular episode that really, since it's home to me, I was on call and someone comes in and the guy was thoughts of taking his life. And here I'm sitting with him and talking through it, trying to understand where he is, what's going on in his life, what we could do to help. And one of the things he said to me was, I am such a burden to my family, and I think they'd be better off without me. And unbeknownst to me, being someone who's not wildly outspoken a lot, I looked at him and I said, I have not one day been better off because my dad took his life.
Wow.
And he just looked at me, and I'm thinking, oh gosh, I've just broken every single rule you can imagine. I'm like, they're going to kick me out of residency, all this. And at that point, we were able to get him into some treatment. And unbeknownst to me, 2 or 3 years later, he came back to find me. And
Wow.
one of my fellow residents got to share with me that, hey, I ran into this man. Do you remember? Went through the story. I'm like, yeah. And he goes, he told me to tell you thank you. He said he had every plan of leaving that night and ending his life if he couldn't get help. Wow. And I just was like, wow.
So how did your family respond? How did your community respond?
Well, okay, so the community that we grew up, it's a place called Coppell, Texas, and they were very supportive, but also very polite, because people don't know what to say when you lose someone unexpectedly. But then when you lose them to suicide, there is that stigma that typically exists for those, and they don't know what to say. And sometimes they would say really stupid things. I was about to say something else, but I figured this is PG, not R.
Thank you for cleaning it up, Chris.
Exactly. But God has a plan. She's in a better place. That kind of stuff. And it's like, I don't believe that there's a God that puts these kinds of tragedies in our life. And I don't think it was his plan. So those kind of things happen. But then the other thing is, we thought, so I'll let Martha share how she dealt with it. But my initial response was to numb my pain. So every problem that needed to be solved for me was at the bottom of a bottle of Chardonnay or rum or whatever. And it got to a point where it was significantly unsustainable. It was ugly. I was messing up my marriage. I was going to games with my son in his second year, not realizing he was struggling, didn't realize he was suicidal. I'm in a game, he gets knocked out with a concussion. I didn't know it at the time because I'm in this business suite. Someone had to call and tell me, because I was too drunk to recognize that he was hurt. And Martha had to call and tell me, your son is hurt. And so I was totally out of it. It got to a point where I eventually had to go get treatment, and I'm 5 years, 4 months, 5 years, 5 months sober. And so
Good for you.
Yeah, exactly. But it helped me to realize that I gotta, that you can't solve your problems just by alcohol. But the one thing I did do that was positive is I poured myself into trying to understand as much as possible about why it happens. And we're not gonna solve the problems, and Martha said there's a would've, could've, should've things, but I wanted to learn as much as possible to understand the scope of the issue, and then also how we could maybe share information with coaches or teachers or parents or clergy people, anybody, any leader of young people, to help them recognize the warning signs and help them, help create mentally healthy environments for those people who are at risk, those who are lonely. You heard Dr. Porter talk about 4 out of 10, significant loneliness. 1 out of 10 have attempted, 2 out of 10 have made a plan. So how do we help people get those situations reversed so that they're not feeling lonely, so they don't feel like they have to have make an attempt or make a plan, but we create mentally healthy environments. So that's sort of,
Do you think that's because, again, it's frightening for people to believe that someone they love or someone they think they know could have an aspect of themselves that they don't know?
Yes.
Yeah.
100%.
What about your family and your community?
Yeah, so, I mean, I was surrounded by support. I had a whole psychiatry residency behind me, so I was fortunate. There wasn't anyone I couldn't talk to, open up to in that environment that weren't there for me. Now, my friends didn't understand, but I was willing to talk about it. They would ask questions. The community was another story. Grew up in Searcy, a lot of Baptist influence, Church of Christ influence, and not to be despairing on that, but they didn't agree that taking one's life was anything but a sin. So that's not the church that we grew up in. It was Episcopal, but we still had to contend with that. But for the most part, people that knew him wouldn't say those kinds of things to us or express things like that. They knew who he was, and they also grappled with how could this have happened. But it changed. There were just friends of my family that no longer were there. They did not know what to say. I don't blame them. They just didn't know what to say, so they thought it was better to say nothing, to just not be around. In fact, there was one guy that never stepped foot in our house again until about 3 years ago.
Wow.
To see my mother, and he was one of my dad's best friends. They did not know what to do or what to say or how to handle it, and they were so afraid it was going to touch them, is what we think. But
Almost like it's contagious.
yes.
Like
Yes.
that there's something that you're going to catch.
Were
Yeah.
you open as a family about the fact that their deaths were suicides?
For ours, there was no doubt.
Yeah.
I mean, as far as everyone knew, I mean, it was a crime scene.
Oh, okay.
I mean, and that's, yeah, so for that day, my mother was with me in Little Rock, and so my dad was at the house by himself. My brother was supposed to go by. He hadn't gone by yet. We tried calling, couldn't get a hold of him, that kind of thing. So we called his trusted friend, partner for 30 years, went by to get him. My mother was driving home and gets a call, you cannot come to the house. So, I mean, there was tape up, there was, police, ambulance, everybody. So it was very apparent. I mean, he had shot himself. But yeah, so we had to go through the whole crime scene process.
I think, to answer my own question, that what I've seen as a clinician is that people shy away when your life gets out of control. They're so scared that theirs could get out of control too, that they want to push aside. They can be the nicest people in the world, but that fear is something that overwhelms them.
I would add, we've never talked to Chris's father again. He said, what did we expect with how we raised Ella? And because we didn't raise her in the right church. So that we never have spoken to him again. And we have a very different friend group than we did. Because as supportive as people were, as many dishes of food that were brought to our home, which was very, very much appreciated, most of those people would never talk to us about Ella again. And they're not bad people. And it took me a long time to understand that they're not bad people, that they didn't want to talk about our daughter. But, if we brought her up, people would walk away from us, literally walk away. They'd start backing away. Like if I'd say something about Ella, I'm not ever going to stop talking about her. I just am not, it's just, She's
Of course
she's
not.
our baby, you know. But some people can't handle it, you know, where it's, you know, almost 8 years and we're supposed to be over it now. And we will never be over it. You don't get over these things. I mean, certainly how we deal with it has changed and it's grown and morphed, but we won't be over it. And my family was very supportive, but I still feel, even with my own family that's always been there for us, almost that like we're okay now, we should kind of move on. So,
Right, right.
You know, the other thing I wanted to say real quick, first I wanted to, so this is Elle. I meant to share this before I turned off the slides a minute ago. And one of the things I always like to share when we show this picture is whenever we talk about, do our trainings or talk about our story, we talk about the importance of checking bias. And one of the types of bias we ask people to check is, what is your bias as it relates to what does a mental health condition look like?
it doesn't look like that.
No, I mean, and somebody mentioned earlier today, I think it was the Let's lady, but how people wear masks and to hide their pain, their loneliness. The comment you made about, you know, burden. I mean, and that was one of the things that broke my heart the most, was that Ella felt like she was a burden, a disappointment, because, you know, she didn't do certain things, or it could have been, like I said, the juxtaposition. Her brother is on top of the world and she's still struggling just being a waitress. But that was, you know, one of the things that I learned. And anyways.
I believe you've shared with me before, she was also bullied for being biracial, right?
Oh, 100%.
Yeah. Let's
So
not,
she wasn't black enough to hang out with the black kids. She wasn't white enough to hang out with the white kids. So it was always a thing. That was, our son handled it in a very different way, but he was also an exceptional athlete. So him and another young man who was also biracial came up with the term, they were both excellent football players, that they were the hybrid nation. And these two had white kids begging to join the hybrid nation. I'm like, I don't think your Southern mommies and daddies are going to like that, but.
let's talk about grief, okay? How do you think the grief of suicide compares with other forms of grief?
Not to suggest that others' grief should be minimized compared to suicide, but it is just different. I mean, there are answers to questions you will never know. And I think that's the hard part. It's the what ifs. And it's what we all have a tendency to do to some degree, is like, what could we have done? Why didn't we see this? What should we have known? And I know that can apply to some other deaths, but most deaths, those aren't the questions you have. You're grieving the loss and missing the life of that person, the effect they had on your life. Here, we're just still trying to make sense of, why did this happen to them?
Even if it was unexpected.
Even if unexpected, it's just, you gravel with that. I mean, to this day, I'm sure there's things that go through my mind about, well, maybe it was because of this, maybe it was because of that. You know, but I will never know what was going through his mind at that point in time. And I think that's hard. And
Yeah.
you have to find a way to come to peace with not having those answers. So it is different, and you feel like you are grieving in silence a lot. Because whenever
okay.
you bring it
So
up,
isolating.
yeah, I've had people where you can be talking about so-and-so passing this, and they'll say, oh, yeah, well, my father died by suicide, and it just like you could hear a pin drop. I mean, it is so, and then they go, oh, I'm so sorry. You know, they whisper their condolences, and it's just a different effect that you experience.
And I would say messy is a really good word to describe it. If my father died from ALS, my brother died from cancer, I can be mad at cancer. I can be mad at those diseases. Yeah. But with my daughter, I was mad at her. Really, really angry at her for a long, long time. And I couldn't think of anything good about her for the longest time. And I really had to work myself out of that. One, we did years of therapy. But I've done a lot of other mindful work, and I've gotten really good at pulling myself out of spirals. But that idea that it was just her, Solomon and I remember driving around with him, and we, oh, it sounds really horrible, but we said when we saw her next, what we were going to do to her. I'm going to slap her. You know, he was going to do this. And, you know, it just, those things that you do, it might not seem right, but it was right. Like,
Because you don't have anywhere to put your anger,
no,
really. I mean,
but
yes,
except to her.
right.
I mean, and, you know, mental health conditions. But again, at that time, we didn't know. You know, we didn't know what we know now. But, you know, it's not as messy anymore because I don't really, I would say that's the biggest way it's changed for me, is that it's not as messy, if that makes any sense. But
Chris, what about you?
I didn't, you just said something that maybe got me going way back and thinking, and I didn't know, I don't think I blamed Ella initially. I blamed myself. I mean, I did blame Ella. I was mad at her, but I also was mad at myself a lot because I felt like I let her down, because the way I work with the kids, I try to always inspire them and challenge them, and sometimes you could be too challenging and too demanding, and I don't think I adjusted my style right enough for her. It worked for Solomon from a sports standpoint, but I don't think it worked for her because of some of the things that she was going through. And so, you know, part of my grief initially was I just was so mad at myself as well. And although sometimes people ask you, did you become suicidal after you lost your daughter to suicide? And I initially always said no, but then I think I was trying to drink myself to death. And I didn't think about that. And I did that for like 3 years. I mean, I was drinking. I didn't drink at all until I met her in college.
such a good influence.
Nothing.
The preacher's daughter.
Exactly, the preacher's daughter. Yeah, I forgot. Yeah, her father and her brother both married us. They're both Methodist ministers. But I didn't drink at all. But I made up for it afterwards. And unfortunately, for like 3 years after Ella died, I was heavy drinking. And I think that was my way of trying to not only solve the problem or numb the pain, but I also think that I didn't care if I drunk drove or if my liver went out, whatever. So I think that was one way of dealing with the grief. But the other thing I'll say about grief is one of the things that helped us through, aside from therapy, was the peer support groups that we went to be around other suicide loss survivors and feeling like we weren't being judged. They got it. They understood. They accepted us. And that was, aside from therapy, that was in church. Our church was very good with us. Ironically, our pastor lost.
Our pastor was great.
Yeah, and he lost both his brother and father to suicide. So he was very empathetic. So having that kind of peer support was instrumental, aside from the therapy, and also.
You know, Martha, you told me when you and I first talked, I was talking to both you and Chris, but that you literally, you went, Solomon was playing for the 49ers at that time, and you went to the 49ers, which was not something you were supposed to do, and talk about Solomon's mental health. That was just a huge no-no. And you said, you've got to help save my son's life.
Yeah.
And so you tread upon this forbidden ground of football in order to do that. And then you were also very aware that Chris might be, and I remember you said, I thought maybe I was going to lose everything and everybody.
Yeah. I really felt like that. I was teaching 7th grade. I'd gone back to school about 6 weeks after Ella died. And I always drew little pictures, but I'm not an artist, so you can't ever see them. But I drew a stick figure holding on to 2 feet. And that's where I thought my family was. I thought I was going to lose Solomon. I didn't know. Once I'd gone into the Niners and told them, you need to get my son help. I mean, really, you know, if you're a parent or if you're a kid, whatever it is, can you imagine your mom showing up at your job and telling them, hey, my son's not doing well. He's really weak right now. I know you need him to be strong, but he's really weak, so you should help him because I can't. You know, which is basically what I did, and um, I thought, even if he never talks to me again, at least he'll be alive. And it took me weeks to actually go in there, and I was so scared. But we had already started to learn, like, what would matter. And as much as I said to him, Solomon, you're not okay, you've got to get help, all he would say to me is, mind your own business, Mom, get yourself help. And I'd say I was getting help. I am getting help, you know, we're going to therapy. But what the 49ers organization did for us, even though I'm still kind of mad at him because they let Solomon go after 4 years, but they set us up. The NFL has a system where you're allowed 6 family sessions of therapy. And so they started us with a therapist, the 3 of us together. Like, Solomon could do as much therapy as he wanted, but the 3 of us together were those first steps in learning how to talk to each other. And as a couple, we got really good at not judging each other's grief. And that was marriage saving, because there are so many times where I wanted to look at him and go, you are a stupid fool. Now, mind you, I did, along with our therapist, we did find the treatment center. We booked him a flight. He wanted to come home. I said, no, you're not coming home anymore. Your choice is to go to a treatment center or find yourself somewhere else to live. And he went. Wasn't easy for any of us, but I couldn't let anyone else go in my family, and I felt like I was fighting all the time. But I don't feel that way anymore, and you know, most of the time my son still loves me. Most of the time Chris still loves me, so it's pretty good.
Leigh Anne, I wonder, I mean, you didn't have your family when or you hadn't had your children, had you?
No. So my story surrounding all that is a little different, which shows even though we have a similar loss, it's still unique, your own experience. And for me, I was struggling myself before my dad took his life. I was in med school, residency. I was separated from my husband. I was going through my own depression, had thoughts of suicide, thoughts of driving off a bridge. I mean, all of this. And what stopped me was, I can't do that to my dad. And
Oh, wow.
not recognizing the struggle he was going through. So fast forward, what happened with him, losing him, that was what got me going, I'm going down the same path as he is. And if I don't do something different, I'm going to end up the same way. So got into therapy with my husband, which he'd been trying to get me to do it for a year, and I had refused. And and so it was like our therapist was like, to me, he's like, look, you got to make a decision what you're going to do here. And so finally we started working through things. And I really, truly know that if my father had not ended his life the way he did, I don't know that I'd still be married to my husband. I mean,
or alive, maybe.
Or alive. It saved my life. It saved my marriage. It got me to look at things in a whole different way. Now, what was going on with my mother and my brother was a whole different situation. I became the peacekeeper, which is what my dad's role had been. And those are not 2 people you want to try to get in the middle of by any means. And their struggle went on for a lot longer. It was probably 10 years out before my brother, I think, truly had a better understanding. But it was rough. It was rough managing them and their emotions and not letting it take the negative effect on me. So
I've got more questions, but what I'm wondering is if y'all have some questions, if anybody would like to ask them questions. Well, yeah, I thought you might. Carla, do we need another mic, or you want to just use mine?
Oh, yeah, we can just pass. Yeah, we can share.
All right.
Oh, y'all can share. Okay, great. Thank you.
Y'all can share one. That's fine.
My question is for Dr.
Bennett.
Bennett.
Leigh Anne Bennett.
Okay. When you were in medical school, and this
Can you hold the mic closer to
yes,
your mouth?
this addresses the issue of physician suicides. Someone had said there's a physician a day that dies by suicide in this country.
2 medical schools full of physicians die every year.
Okay.
Yeah.
Well, I heard Keonta say that statistic. When you were in medical school, in your psychiatry rotation, did they ever address, some of you will develop some of these disorders? Because, and I wonder if that's a factor, because I've known my father developed mental disorder, not suicidal, but he waited a long time not to get medication. I think there are other physicians who wait too long to get medication. But I saw if it's part of the medical school curriculum, maybe some of you will develop these disorders. They might know what to do a little better.
So they have in medical school, they have student mental health. But back in my day, they may have come and talked to us once, but we knew they existed. I think nowadays they do a much better job. It's not necessarily just like a specific part of the curriculum, but they go around to the medical school classes, to the residential programs, and they actually talk about their mental health. But 24, 25 years ago when I did it, no.
Do you think they're telling the truth?
I do. And part of the reason I say that is I happen to know the individual that is now in charge of doing that, and she and I talk often about it. They're a lot more open about it. Within 3 years of my father's death, there was a cardiothoracic surgeon at Children's Hospital that took his life. Yes. And I was asked by Children's Hospital to give a talk on physician suicide. Great. There was no information. This was in 2004, 2003. When I say no, there was a little. I had to dig. I kept looking and coming up with as much. I had to do an hour and a half talk. And so what I started doing at that point for the first year psychiatry residents, I started doing their suicide prevention talk when I was still a resident. I asked them if I could do that, talking about how we channel things, our own grief. And so through that, I bring that to light, and I let them know in that room that they are at a higher risk of suicide than most people, and kind of give them a forum to talk about it. So I think it's better, but I don't know that it's incorporated to the extent it needs to be.
Then I think you had a question over here. Somebody had a question?
What was it?
Yeah, this is maybe a little weird, but something resonated with me that you said about feeling so isolated and people treating you like it was contagious. And I think there is a little bit of that notion really there, because there was a young man who died by suicide. He was a senior in one of the big schools here in Little Rock. And I know that even by counselors, parents of friends of his were advised not to let the friends get too close to that family, because they said research shows that frequently that has this effect, that it models this, the behavior, and your own child would be of higher risk to do that. And I just find that, I was just so stunned by that. And so I don't know, have you ever heard that this is kind of advised?
I've never heard that as a teacher. I know that there's, I think they call them clusters of suicides, right? But I don't.
Suicide contagion, I've also heard that.
Yeah, that's a sensationalization that goes.
Yeah, but I don't think not talking about it and not grieving your loss, I don't think there's any research that shows that helps. Oh, no. Yeah. Oh, yeah. Yes.
What would y'all say to someone who had a suicide attempt and survived and is experiencing that same alienation, isolation, even like a disgust from other community members, people who see this person and walk in the other direction? Someone who is feeling a lot of guilt and shame for what they did.
Gosh, that's a tough one. I mean, I would want them just to look within family, friends, anyone that they do have in their life that would be supportive of them. Looking into other organizations, support groups, someone that can help them not feel alone. So like we have for people who've lost a loved one to suicide, we have survivors of suicide support groups, but those aren't typically for people that have attempted suicide. And so we need things like that too. Now there may be in some of the other states, but okay, there may be some now, or they may allow that, but it's a very good question. There's not as much support out there for those people on that side. Now the hope is true that they can get into seeing people, professionals, but that there are people in their lives that they can reach out to.
Well, and I would say make sure that that person is aware of the hotline numbers and the text numbers, because I think the new research is someone is actively suicidal for 10 minutes. They used to say an hour, and now it's 10 minutes. So if that cycle, if that can be broken, that person can get the help to get through those times, hopefully. But the isolation is something that none of us can take lightly. We have to figure out how not to be there, right?
Well, you've drawn me to a point that I'd really like to make to this group, and we talked about it when we met. In my research for Perfectly Hidden Depression, I found this man, Edwin Schneidman is his name, and he founded the American Association for Suicidology. And his work was taking place at a time when the DSM was coming forward and saying, you've got to it's the diagnosis of depression, that's going to be the forerunner of an attempted suicide or suicide. Depression, if you find depression, you look for suicide. And Schneidman didn't believe that was true. He believed that what he called psych ache, which he defined as intolerable pain, like you said, maybe for 10 minutes, but intolerable pain that you could not necessarily find a way around. And when we think of it that way, who was it that said suicide was a failing, a moral failing, a spiritual failing? We still have those attitudes. And I mention this simply because of the comments. I was honored to do a TEDx in 2023 about Perfectly Hidden Depression. And in it, I said, it won't be long before all of us knows someone or knows of someone who died by suicide and their life looked perfect. So I think it's about also, and I would try to talk to this person about, and I would talk to anyone I could talk to about it, to normalize the idea that I don't know how many hundreds of people have sat on my couch and said, sometimes I think about driving off the road. And I don't go, oh, we've got to get you to the hospital. It's like, well, let's talk about it. Now, obviously, there is a line which you have to walk very carefully with someone to see about whether they have a plan or how close they get. And that's what you're going to hear tomorrow with John Summers Flanagan. he has this strengths-based suicide assessment that is about encouraging talking about suicidal feelings, like you would talk about anger, like you would talk about fear, like you would talk about jealousy. And so the whole idea is to encourage people to talk about it, because I don't want you to raise your hands, but I bet you there are some people in this very room that have thought about suicide for themselves. And you may have thought about it for a second. You may have thought about it for an hour. You may have thought about it for a much shorter period of time than even that. But it still crossed your mind. And that's what is so important for us to understand, that if we normalize these, that, and I think that's, a major message to mental health clinicians, is that we can't be scared to talk about it. Chianti this morning was talking about how, if I ask you if you ever felt suicidal, I hope you don't say yes. What am I going to do? And I unfortunately think a lot of our training teaches us to dread that. So instead of going forward, sorry, I'm getting on my soapbox. So instead of going toward that conversation, we want to avoid that conversation. I have had 2 clients die by suicide, current clients of mine, and it was a horrible, well, obviously it was tragic for them and their family. It was horrible. And I wouldn't want to live through it again. I hope I don't. But I'm still not, I have not backed off. If anything, I go much more forward in my talking about, well, where are you with your suicidal thoughts? What is happening to them? You're shaking your head. Okay, I'm going to get off my soapbox.
No, I think you're right on. What we've talked about in the last 5 minutes is just the importance of normalizing the conversation and also educating people. There are so many myths out there about mental health and suicide. And I think like talking to somebody is going to put it in their head, or only experts can handle somebody who's suicidal. And I really do think we need to, from kindergarten all the way through medical school, need to be teaching people about feelings, emotions, suicide ideation. There are 16.9 million people in the last 30 days who've had suicide ideation. I listened to a really good colleague of mine and fellow board member at AFSP, Dave Jobs, talk about 60 to 70% of people think about, like you said,
Yeah,
wanting to die by suicide, but they don't act on it. So it's not something to shy away. We got to talk about it, and we got to equip people with tools, knowledge, language to have the right kind of conversations. I'm still amazed from a language standpoint, the number of conferences I go to, and to hear talented, well-meaning people say they committed suicide versus die by suicide. And people don't commit cancer. They don't commit lung disease. They die by lung disease, or they die by cancer. So I just feel like there's a need to have this type of education, discussion, conversations on a regular basis, so we help people know what really is going on.
Well, and having suicide ideation is nothing to be ashamed of.
no, it's not. Y'all believe that? Really, honestly, you don't have to shake your head. Just think about it. Think about yourself. You're going to look in the mirror and think, no, I think it's, I can talk about it. I can talk to my friends about it. I want to hear about it. I think it's a difficult, because we are responsible. They are under our care. And so it is, it's scary. It's, they walk out of your office after the session and you've talked about this, and are they going to come back next week? Are they not? I mean, how do you know? And you don't know. You just count, it's frightening, and it's something that I think we all have to deal with.
I know that for me, I realized I had reached kind of a milestone in my career, I guess, when I could let someone walk out of my office with suicidal thoughts and not feel like I had to put them in the hospital, that I had to make sure they were safe so I could rest easily that night. I mean, that I needed to go extra measures just for my own sake, that I could actually let them walk out that door knowing that we talked through everything, that I felt that it was okay for them to go on and not be hospitalized. And once I say comfortable, you're never comfortable with it. You're always concerned, but I knew that was the right decision. That's when I knew I had gotten to a much better place with it, and that I could openly have that conversation with them and just talk about it and not make them fearful that they're going to say something that's going to cause me to call 911 and have them committed. And so it's possible to get to that point.
Any other questions right now? Yeah, sure.
Were you able to have any closure or discussion? No, closure is not the right word, but with Ella's therapist? And if so, what conversations or words were helpful, what were hurtful? And same with your dad as well with his psychiatrist.
With Ella's therapist, I referred her to him when she had moved back to Capel. And he said to me, I didn't see this coming. I will never get over this in my life. He helped us quite a bit right after she died, and I still worry about him. I still really, really worry about him. And I hope he's okay. One thing I didn't say, when Ella did die, it was an active homicide investigation for how many weeks? Like 8 weeks. And when they came back and they said, yes, it was definitely a suicide, but they called it aggravated and impulsive. And I think for him that made a bit of a difference, since he was treating her and didn't see it coming. But one thing that he had done, so she had started not showing up to therapy, and so she had missed her previous 2 appointments. So he said, I wasn't going to bend over backwards to get her in. I had made, so he said she called me to talk to me, and I told her I couldn't see her. She called on Monday, and I couldn't see her till Thursday. And she died on a Tuesday. So I don't know how, as a therapist, you deal with that, except that he didn't know. Just like we didn't know. I don't blame him at all, or we don't. And her doctors didn't know. She had been to the GP 3 times in 2 weeks. She was trying to, she's like kind of the classic case, right? She was trying to figure out what was wrong with her, and nobody asked her, including us. If we're going to blame anyone, we have to blame ourselves, so we're going to not blame anyone.
One of the clients that I had years ago, her name was Karen. I'll never forget her, like your doctor. I went to her funeral, and she literally walked out of my office, and 15 minutes later, she was dead. And so I went to her funeral fully and I told her family I was coming. They said fine, but I was still kind of expecting some kind of, harsh or, just I really didn't know how I would, or how they would treat me. And her mother came over and said, we know you did everything you could. And we feel for you that this happened right after you saw her, which of course was incredibly compassionate for me. But I remember what had happened was this young woman who I'd worked with off and on for about 2 or 3 years, she just found out that her son had been diagnosed with autism, and she didn't think she could handle it. And that's what she was talking about that day with me. I don't think I could handle it, and blah, blah, blah. And so, anyway, that was her straw. That was the thing that she couldn't face. So, whether I handled it right or I don't know, I handled it the way my gut told me to handle it. And so I do think our profession needs to have some training and talk about what we talk about is how you hospitalize somebody. That's what we talk about rather than talking about, how do you hear this and encourage hearing it and give them a safe space and handle your own feelings in so doing. So, any thoughts about that? Yeah, sure.
Margaret, I would say on kind of that, like, up to mental health professionals to kind of step up to the plate and do that. I'm early career still. I got a couple months left before they transitioned me out of early career, but I don't know if I even got adequate training
No.
in grad school. And
No.
thinking about it being, less than 10 years ago, and I work with kids. So, like,
You were probably told to make a suicide plan.
make a suicide plan, which
They don't
or
work.
anti-suicide plan or safety plan. I'm like,
Yeah.
oh.
John will tell you tomorrow those
Yeah,
don't work.
so I'm looking forward to that. But I would say that even now in mental health professions, at least in the hospital settings, we still rely on our social workers to come in and do that, and they have a lot more experience than what I feel like I have. So this is, I think, very timely, and I think it's going to be a good way to kind of supplement some of the training that many of us have missed.
Yeah. Well, thank you for that.
I work in a setting where I'm by far the oldest and also the only psychologist. And I work, there's like 10 therapists who are counselors and social workers. And I feel, and they're still early career, still pretty young. And I feel that they're really afraid of having, and I'm too, but I'm just now a little more relaxed and have more experience. So, and then they use this rating scale where they have to do a suicide risk assessment. And then they are very quick to tell the parents, you have to take your daughter, your son, to a hospital because they just cannot carry that. They feel they cannot carry that responsibility. And I'm not here to judge if that is appropriate or not. I just notice it happens quite often. And then they come back and they don't talk about that anymore because they know that if I bring that subject up, I'm going to end up in the hospital again because
Exactly
these
right.
are also minors,
Exactly
that I
right.
work with teenagers and so they tell the parents and then the parents freak out. They get very, very anxious and on their way they are to children's hospital or to the emergency room. And it's like we call it drehtür, it's like in and out, in and out. And as you said, there is no room to really talk about it, I feel.
There was
But
an example.
it is a difficult situation because I cannot sit there as a senior kind of person in that clinic and tell them, just say, oh, just don't send them to the hospital. That's not like my
You don't
position.
want to make
So
us
it is
strict.
it's a difficult place to be.
Mm-hmm. Yeah, I want to say.
To me, that just goes back to the training. What are we not doing? And this is for psychiatry as well, psychologists as well. What are we not providing y'all in your training so that you can handle those situations and at least be more comfortable with that there are a lot of options to consider and that you're not the sole responsible one for what happens.
And you don't give somebody a Beck inventory and they go, no, I'm not hopeless. No, I'm not helpless. No, I'm not. And then you go, okay, well, that's good, because in my book, there was a guy who told me his story, and he had gone to a psychiatrist, and he had done exactly that. He had not checked off anything. No, I'm not hopeless. No, I'm not helpless. No, I'm fine. I'm fine. And so the psychiatrist said, I'm not real sure why you're here, and, whatever they said. Well, 3 weeks later, he tried to kill himself, and the psychiatrist heard about that, and to their credit, came to see him. And he said, I think it was a he said, "You were just in my office 3 weeks ago." And the guy said, "Well, you didn't ask me the right questions. The question should not be, do I feel hopeless? Because if I'm hiding that mask, I'm going to say no. The question should be, even if you tell the truth then, if I were hopeless, would I tell anyone? Probably not. You know? So, and again, we're not mind readers and all that kind of stuff. I don't want to have somebody think you're supposed to be some guru and know all this stuff about other people, but gosh, it's important to ask lots of questions.
Hi, I was thinking about the undergraduate students here who, haven't worked in this field yet.
Probably
and
scaring the shit out of them right now.
So that's what I'm thinking about. So just to add a little context for them, I wanted to add that as a clinician, having worked for about 5 years before going into teaching, working with kids, I ran into people experiencing suicidal ideation, at least that they told me about. It was pretty infrequent, maybe a few times a year, and that may have been because I mostly worked with anxiety and autism. But I wanted to know from those of you who do work with people and their mental health, how often do you tend to run into this, just to give them an idea of kind of what that's like? And do you have any tips for, since it doesn't necessarily happen a lot, I think sometimes we can be a little rusty in exactly how we approach it. Is there anything you do to keep your mind kind of refreshed there so you handle it smoothly?
Anybody want to answer this who's also a clinician? I mean, I have my perspective, but it's only my perspective. I try to look at a lot of research about suicide, so what's going on in the field, and I don't just count on my own patients to broaden my experience. I do know some patients will come in from time to time and say to me, for example, maybe they're seeing a psychiatrist or a primary care physician, and they try to talk to them about it, and they're well, if you're suicidal, then I'm not sure, they back off from it. So any other clinician here have, yeah, go.
From the old lady in the back.
Watch that.
worked
There's
with-
an old lady in the front, too.
Yeah, the two old ladies in the back. I'm older. Been in clinic over 20 years, 10 years in community mental health, 10 years in private practice, 0 to 86, I think, is my oldest. And I will tell you, it comes up weekly. And I don't want to toot my own horn, but just in part of the training, to be confident, be genuine, and that's how you start opening up conversation. I am who I am, and from day one, we're asking about suicidal ideation, we're normalizing it. I tell them in my intake what my policies are, because kids will ask, but adults won't. Kids will be like, what are you going to tell my parents? What would you? And so I kind of tell adults, here's what I'm going to tell you. And talk about the difference between, you can think about it, you could have felt about it, you could have said, it'd be easier to drive in front of a Mack truck. And I'm not going to freak out, because there is kind of a science to this and an art of the difference between a barometer of how much pressure you're feeling and an emergency of how desperate you are to not be in pain. And so I ask them, how's your pain today? How's your desperation today? In the intake, they find out that their therapist cusses. Some days she's going to wear jeans. Other days she's going to wear her fancy skirt. And all my clients know what my fancy skirt is. That you have to be genuine and open and not afraid. And that's what we've been saying over and over again, is just, you can talk about it. We've thought about it. We're people too. Our kids have thought about it. So in my time, I've had more kids than adults that would admit, early on, to having thought about it. Adults are more and more now, we talk about it on the weekly basis. I've got one client that is continually has suicidal ideation just from being old. And so we talk about it, and I'm like, well, I look forward to talking to you about this next week. And she's like, thanks, I will probably talk about it next week. And there's just a lot of grief and trauma in her life. So we talk about it openly, and just to be genuine, just to be happy to talk to them about it. Not like, Giddy, I'm so glad, I get another paycheck, your suicidal day. But just like, I'm so glad that you told me. I'm so glad that you were brave. So I have confiscated medication one time, because that was their plan, and they came into my office and they brought their medicines and said, this is how I'm going to die today if we don't have a plan. I'm like, cool. I'm so glad you did that. I'm like, and they kind of weren't ready to hand it over yet. And so we just sat and talked, and I'm like, I can't let you leave with your medicine. So who am I going to give your medicine to? Or am I going to have to come to your house and give you your medicine at 9 o'clock tonight? And so just a little bit of that humor, like I am taking it seriously, but there is another feeling on the other side of this. And so I confiscated their medication until one of their friends came and took them for the weekend and was going to give them their medication. And that person is doing amazing. And this was 6 months ago. And they are just, and we talk about as follow-up, when you say they don't say it again, it's like, well, are you glad that I took your medicine that day? And they're like, bitch, yeah, I am. Yeah, I know. We just went to R.
Yeah.
Sorry, online folks. So just be honest, be genuine, develop that rapport, let them know that you care and that you're not afraid to talk about it so they can tell you where they're at. And you're like, cool, I'm not going to overreact. But if we have to go to the hospital, it's going to suck. Hospitals aren't that great for the people in the back. But, it's just to see what's happening until you feel confident that you can control what's happening with yourself, and then we'll just keep doing this. And sometimes they'll see people 2 and 3 times a week until they get over it.
Yeah.
So don't be afraid of it. The only suicide that's happened in my clinic was actually a murder-suicide, and we had no idea it was coming. So that is hard. But I've worked with the family since then, and they're all doing really good too, because they talk about it now too, openly, even though the community is weird. But they're just advocates for, let's talk about this. So don't be afraid.
Thank you.
It's not as scary as you think. If you're scared, they'll be scared. Don't be scared.
I'd like to hear about your foundations and your nonprofits that you've started. Oh, sorry. Oh, I couldn't see. Sorry.
I was going to answer your question. It's been about 15 years since I was a therapist, so this is dusting off old neurons here. But I would say it would come up often that someone would say they wanted to die or whatever. And what I would ask them was, they would say, I would kill myself. And I would say, okay, are you wanting to take your life, or are you not wanting to live like this anymore? And what I found was whenever I'd ask that question, most of the time they were like, I just don't want this, whatever it was. It wasn't that they were actively suicidal. That was their way of getting into a different conversation. And so I would have to say the actively suicidal folks I saw was not as frequent as people who just would say that to segue into a different conversation.
Great point.
Thank you, and I will make this brief. I commend you, Margaret, for bringing this discussion. Dr. No, I didn't mean to say that. But thank you for bringing this topic to this conference. And I think there's a need for us as clinicians to discuss this in more depth. I've not known us to do this through ARCA.
Talk about our fear.
Our fear, talk about the experiences that we've gone through when we've had patients who have made that choice. That was a part of my training many, many years ago. And I'm very thankful for that. And yet, there is no foolproof protection. We had a faculty member while I was in graduate school doing a holiday weekend. And it was devastating for everybody. Um, so I think it's good for us to have this discussion, and I think it's good for us to dialogue, especially as clinicians. But the bottom line is you can cover all the bases, check all the boxes, and who knows what happens after you've done that once they leave your office, because it can happen to any of us. So
Well, thank you for that. I appreciate that.
Any more questions? I got a comment, because I'm just amazed. I'm always amazed at how this discussion goes. People talk about the lack of training, the lack of curriculum, guidelines, recommendations, best in class. And Martha and I have worked with some people like yourself, people like Dr. Stephen Stahl and Dr. Christine Moutier, great people in the suicidology field. And I'm just amazed that whether you're a doctor, clinician, a veterinarian, a construction worker, a teacher, a coach, a psychologist, a psychiatrist, I mean, it doesn't matter. Everyone has the same issue, that they feel like they're not getting the right amount of training. And I'm just wondering, what is it going to take for us to put together a plan that says that whether you're a pediatrician or you're a psychiatrist or you're a high school coach or a middle school coach, you heard Dr. Porter talk about 10-year-olds who are dying by suicide. We got to figure out a way to set up a curriculum where we start addressing and having these kind of conversations on not a one-off, but on a regular basis. It's got to be part of the curriculum. And I don't know what it will take, but I hope we're not here 2 years from now saying the same thing without anything concrete in place in these key special fields. Sorry, I'm on my soapbox now.
Well, that's fine. Do you have anything to say about that? No.
I just commend all of you for doing the work that you do, you know, and how important and impactful it is. And for those of you who are comfortable asking the questions, that's amazing. And I hope that for those of you that aren't, that this conversation has helped you want to ask them more often.
Any other questions? I'll go back to mine to talk about what your nonprofits have meant to you, and what's been your experience with taking your story so public and all of that.
So, like I'd said initially, for ours, it just began with a bunch of close family friends that knew my father and wanting to make a difference, wanting to continue to do what he would want us to do and improve lives of other people. And so that's how it started. And it was when we were in our 15th year that I was asked to give every year around my dad's birthday in September, we would have an annual dinner. And we would thank all of our sponsors, and we talked through all the things that we'd been able to do through the support of other people. And they asked me to give a speech for the 15th. And so I did. And I had looked out at the crowd of people, and very few of those people that were now actively involved even knew my dad. And that was what was so amazing to me, is it started because of people that knew my father. They did want to understand depression better. It took them a long time before they had any real good understanding of what we could really do to help, but they wanted to. They tried, but it was because of my dad they did it. What continued and continues to this day isn't about my dad, and that's the part that has meant so much to me, is that they want to keep that. They have the passion. They're being fueled for other reasons outside of just who my dad was. And we've had the opportunity to go to schools and give talks. We have an annual Understanding Depression seminar every year. We do a walk. It's always the first weekend of April, and it's called Stride to Prevent Suicide. And we had a poster, a big thing of posters that we would take around. We had one of the local universities that their art department, that was their project, was to put together all these different posters on depression, suicide, statistics, and libraries across the state would ask to have it and show it. And of course, I'm kind of dating myself because libraries aren't the big thing as much as they used to be. But so just whatever they could do to talk to communities, to go out. We offered the ASSIST training as well at one point. You heard a lot about the American Foundation.
Can you talk about what ASSIST is?
well, I may not be the best one to talk about it, but it's the applied suicide intervention skills training. And it was going out helping people, the kind of first line people who are going to be the ones for kids or adults, and help them to better understand what to look for and how to help get them the treatment that they need. But we would do things like that. And one of the other things I'm trying to think there's just been a lot of different things. I could go on and on about all the different, I've just been so proud of the group. I haven't had as much involvement in it of late, but we do a monthly SOS group. And I think that has probably been the thing. We've been doing that almost, 20, 23 years. That's probably made the biggest impact, is giving people a safe place to come and share their story. So again, I'm very proud of all the ones that have continued the work, and I think they're making a difference. Yeah.
Okay, so initially, Martha and I just really delved into working with American Foundation for Suicide Prevention, NAMI, Mental Health America, et cetera, and then we got to a point where, you should describe what you did when you went back to school.
Well, so I went back to school, and I was like, you know what? I'm suicide prevention trained. I've watched the same 20-minute video for 10 years. This is not enough. It's not okay. And so I really thought that we needed to work with leaders of young people. It is not sexy. Nobody wants to pay for leaders of young people to be trained. I got to tell you. I mean, they want to train the kids. They want to bring these programs into the kids and have the untrained teachers teach them to the kids. So I really felt like there was something missing in so many programs. But if we provide, as teachers, see these students in a fairly safe, supportive environment most of the time. But it's constant. It's the same hallway, it's the same classroom. So as an educator, I know a lot about a kid that a parent might not know. And when I was coaching and teaching, I spent more time with my students than their parents did. And they don't like to hear that. They didn't like to hear it. But after we lost Ella and I started learning more, I felt a lot more comfortable calling parents to tell them what I saw. And most parents didn't want to hear it, but if I didn't tell them, nobody's going to, right? Like, educators are in this unique position. So we go in and we train educators, leaders, any leader of young people to we open them up with our story. When we tell our own stories, people listen differently. Your hearing all of a sudden opens up, and we're not sharing any new information. We're not out there doing research, but we're sharing what we've learned and what's out there. We're immensely grateful to the American Foundation for Suicide Prevention and so many researchers that have helped us along the way. But if those teachers, leaders of young people, can have their hearing fine-tuned, they can get the information that they see, that they know. I can tell a kid, oh, you need to go see the school counselor, which in Texas, they are not trained. I don't think they are, probably in Arkansas. By law in Texas, as soon as you're a school counselor, you are considered a licensed clinician, which is really scary. But the kids don't want to go talk to the counselor. Ours were 600 to 1 counselor. They didn't know the counselor. They wanted to talk to us as teachers. But if we knew what to say, who to refer them to, help them call their parents, help them know what resources are out there, get them to those resources. Dallas ISD has a licensed clinician, a real licensed clinician, on every campus. Not all the teachers even know that those clinicians are there. We're just trying to get people to the places. We're not trying to make anyone a clinician or have anyone speak out of turn, but if people know what resources are there, if they know not to be afraid to ask questions. the world will be a better place, in our opinion.
No, I think that's good.
Well, we're a little early to quit, but I think kind of if this is a good point to just, I mean, I cannot thank the three of you enough. I cannot thank you enough. And so why don't we take a break? I hope those of you who are members of ARPA will stay for a short business meeting. And because we've got some exciting things going on, maybe we'll, I don't know, should we move that time up from 4 o'clock to maybe 3:45? Our ED is saying yes. Yep, Judd is saying yes. All right, so why don't we take a 30-minute break, and at 3:45 we'll have a short business meeting. I promise you it'll be short, and go from there. Thank you so very much.